Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh and a very good day. We are from Group 7B and we are going to present our pediatric cases. I will start with patient information. Patient is a 3 years old Malay male boy that was admitted on 1 October 2019. His weight is 13.1 kg with height of 92 centimeters. His BMI is 15.48 kg per meter square and body surface area of 0.58 meter square. Patient came in with a cough, non-productive, non-hemoptysis, associated with post-tussive vomiting, worsening throughout the day and affecting his sleep. He also had a runny nose for 2 days with a clear discharge, fever associated with rigor for 1 day, rapid breathing for 1 day. He had used MDI salbutamol 2 puff and he had a reduced oral intake for 1 day, which is half of his usual amount. This is his 5th hospitalization due to respiratory symptom. Family history consists of his mother, which had allergic rhinitis, and he had one younger brother which was recently admitted for bronchiolitis and history of frequent need of nebulizer. His father is a smoker, but his father claimed that he did not smoke in the house and both of his parents take caffeine. Patient was exclusively breastfed for 6 months and then weaned off to solid plus breast milk. He is currently taking 3 main meals per day plus 6 ounces of formula milk 5 to 6 times a day. His birth history consists of cesarean at 40 weeks and 5 days. His birth weight was 3.1 kg. He had completed all the scheduled immunization and there is no additional immunization given. Patient developmental history consists of patient is able to run, walk, goes up or downstairs, pedal tricycle. He also can copy circle, towers 5 cubes and can count up to 10. He eats independently and plays with other children and wash his hand. Previous admission history of patient consists of on March 2018, he was admitted due to RSV pneumonia, June 2018 due to bronchopneumonia, September 2018 due to viral pneumonia, December 2018 due to viral-induced wheezing, July 2019 due to mild persistent bronchial asthma. He has no known drug and food allergy. Other information related is patient was sent to babysitter from 7:30 a.m. to 6 p.m. and there is around 20 children in the babysitter house. His interval symptom, there is no nocturnal and daytime cough. There is the presence of exercise-induced cough and the trigger factor is usually URTI, smoker and cool weather. His G6PD is normal. First diagnosis is acute exacerbation of asthma. Before admission, patient had multiple admission to hospital due to viral infection. Patient also have non-productive cough which worsening throughout the day and affect his sleep. He had rapid breathing and poor response to MDI salbutamol 2 puff. On 1st October, patient is tachypneic with 44 breaths per minute. Patient has onset symptom of respiratory tract infection, prolonged expiratory phase and experience minimal intercostal retraction and subcostal retraction. The second diagnosis was pneumonia. On 2nd October, patient is having fever with temperature of 40.6 degrees Celsius. His chest X-ray revealed left perihilar haziness and right midzone consolidation. Patient also has high neutrophil and CRP, which indicates infection. On 3rd October, there are bilateral cracks, more on the right lung. On 4th October, culture and sensitivity result came back negative, which means there is no growth of bacteria and virus. Patient temperature is 38.9 degrees Celsius, which indicate there is still inflammation. He also had on-off chest cough and fine crabs over right lung. On 5th October, patient is still having slight fever, which is 37.8 degrees Celsius. Patient is still having chest cough and bilateral crabs more over right lung. On 6 October, patient is having on-off chest cough. He had high temperature, which is 38.2 degrees Celsius, fine crab over right lung, and high lymphocyte, which indicates inflammation. On 7 October, patient still have on-off chest cough and high temperature, which is 38.6 degrees Celsius. His chest X-ray shows worsening over the right lung. On 8 October, patient still have on-off chest cough. His culture and sensitivity blood result is negative as there is no growth of bacteria. His urine test is also negative. On 9 October, patient is still having fever. This is the list of current medication that the patient is taking. To relieve fever, patient was given syrup paracetamol and suppository paracetamol. For bronchial asthma, patient was given syrup prednisolone, nebulizer salbutamol, MDI salbutamol, and MDI budesonide. For pneumonia, patient was given IV benzyl penicillin, syrup penicillin, IV cefuroxime, and syrup cefuroxime. Syrup loratadine was also given as off-label use for bronchial asthma. This is the treatment guideline for acute exacerbation of bronchial asthma, ABA, according to Paediatric Protocol 4th edition. For mild asthma, it was supposed to be treated with nebulized salbutamol or MDI salbutamol plus with spacer, 4 to 6 puffs for children aged less than 6 years. For oral prednisolone, 1 mg per kg per day with maximum doses of 30 to 40 mg for 3 to 5 days. If there is no improvement, they should be treated as moderate, which consists of nebulized salbutamol plus minus ipratropium bromide plus oral prednisolone and also oxygen for 8 liters by face mask. Patient was given nebulizer salbutamol 4 hourly. There is no unclear dosage given. We suggest dosage of 0.15 mg per kg per dose with maximum of 5 mg. Patient also received oral prednisolone 15 mg OD. According to patient weight, the dose prescribed is appropriate. Patient received nebulizer solution right after admission and received oral prednisolone after 3 doses of nebulizer salbutamol. Patient was on oral prednisolone for 1 day only, which is on 2nd October. Prednisolone should be given together with nebulized salbutamol as the management of mild ABA for 3 to 5 days. We suggest dosage of 1 to 2 mg per kg per day for 3 to 7 days. Patient also was given MDI salbutamol 200 microgram. Given dosage was 2 puffs 4 hourly and 2 puffs 6 hourly. The dosage prescribed are appropriate. MDI with dedicated spacer with face mask was preferred for children in between 0 to 3 years old. Studies has reported MDI SABA delivered via MDI and spacer as effective as nebulized SABA. Thus, the medication prescribed is appropriate. Patient was also given MDI budesonide for 200 microgram, 1 puff BD. The dose prescribed to the patient is appropriate. Glucocorticosteroids are the most efficient controller therapy in asthma and can be introduced in step 2 of the management of asthma for all ages of children. It can prevent difficulty in breathing, chest tightness, wheezing, and coughing caused by asthma. Medication prescribed is appropriate. Patient also receives syrup loratadine 5 mg at night. Antihistamine is not recommended for management of acute exacerbation. Study shows H1 and H2 antagonists cannot block patient asthmatic change. Improvement of PEF during initial phase of loratadine treatment decreased with time, which suggesting tolerance of patient to bronchodilatory effect of antihistamine. By considering lack of significant study on children less than 5 years old to support the indication of loratadine, suggested that loratadine was not suitable to be given to the patient. Appropriate treatment for bronchopneumonia according to the Paediatric Protocol 4th edition for first line is supposed to be given beta-lactam, which can be benzyl penicillin, amoxicillin, ampicillin or amoxicillin clavulate. And the second line consists of cephalosporin, which is cefotaxime, cefuroxime or ceftazidime. Comment on management of bronchopneumonia. Patient was given IV benzyl penicillin 650,000 unit QID. The doses prescribed is appropriate. Patient received the medication on 2nd October after diagnosed with pneumonia. This is the first line antimicrobial agent for fully immunized patient. The medication prescribed for the patient is appropriate. Patient also received syrup penicillin V 195 mg QID. The dosage prescribed to the patient is appropriate. Patient shows no spiking temperature with benzyl penicillin treatment, which may show a good progress to resolve pneumonia. However, syrup penicillin is given to replace benzyl penicillin on 4th October. Patient experienced drastic rise of temperature. In severe infection, dosage of benzyl penicillin can increase if necessary to 50 mg per kg every 4 to 6 hours, with maximum per dose of 2.4 gram every 4 hours. Change of penicillin V from benzyl penicillin is inappropriate. Patient also received IV cefuroxime, which is 328 mg TDS and 660 mg TDS. The dose prescribed is appropriate and we can consider to increase the dose if infection becomes severe. This is the second line antibiotic for pneumonia, where it needs to be considered when there is no sign of recovery or patient remains toxic and ill with spiking temperature for 48 to 72 hours. Thus, the medication prescribed is appropriate. Patient was also given syrup paracetamol 185 mg QID and suppository paracetamol 250 mg. The dose prescribed for this patient for suppository paracetamol is inappropriate. This medication was given to relieve fever due to infection. Medication prescribed is appropriate. However, the dose of suppository given is lower than it is supposed to be given. For drug-related problem, first, potential ineffective asthma treatment due to secondhand smoke. People with asthma who were exposed to secondhand smoke have a higher risk of asthma attack. This may cause more frequent use of reliever inhaler. High SABA use will increase asthma exacerbation and mortality. Next is poor adherence on medication. Based on medication adherence history, patient has poor adherence level. Previous assessment also claimed that patient is not adhere to MDI budesonide. Poor technique of using inhaler. Based on medication adherence history, patient's caregiver has poor inhaler technique. Previous assessment show that caregiver have poor technique on using inhaler with aero chamber. We need to review the technique in using inhaler to optimize the therapeutic effect of active ingredient. Spacer can be used together with the inhaler. Next, potential adverse effect of inhaled corticosteroid. Budesonide may cause local adverse effects such as hoarseness and oropharyngeal candidiasis and coughing. Rinsing mouth with water after each use of inhaled corticosteroid may prevent this effect. Possible side effect of antibiotic. The common side effect of antibiotic are nausea, vomiting, rash, and diarrhea. Monitoring parameter for this patient is, for effectiveness, vital signs such as body temperature, respiratory rate, and heart rate. Indicator of infection and inflammation such as white blood cell and C-reactive protein. Chest X-ray, blood culture, assessment of asthma control such as interval symptom, frequency of exacerbation, peak expiratory flow rate. We also need to monitor the proper hydration for effectiveness. Safety profile consists of renal profile, hepatic profile, sign of anaphylaxis during first dose of antibiotic, and possible side effects such as GI discomfort, rash, and oral thrush. Pharmacist intervention, patient and caregiver education. Educate about the correct inhaler technique with dosage form plus pacer. We need to ask to demonstrate before the patient discharge, and we need to advise to make sure that patient always rinse his mouth after using inhaled corticosteroid to prevent oral candidiasis. Next is adherence issue with the caregiver. We need to interview for any difficulties regarding adherence and explain the importance of patient compliance to his treatment and common side effects. We also need to provide medication adherence enhancing aids if needed. Smoking cessation. We need to encourage his father to reduce smoking slowly. We also need to ensure patient to come for follow-up, as we need to assess patient condition is under control and the effectiveness of treatment. We need to remind the caregiver to give cooperation to bring the patient for follow-up since both of them are working. We also need to provide asthma action plan, which how to treat asthma exacerbation and how to recognize it, how and when to seek medical assistance. This is the reference used for the study. Thank you.